Hi, good afternoon. Thank you for the opportunity. So I'm Luis Castro from Barcelona. I'm going to present our review, single center experience about transurethral endoscopic excision of exposed meshes removed with the Holmium laser. These are my disclosures. So, as we all know, since the introduction of the TBT and the TOT, there are high cure rates for stress urinary incontinence. But as we all know, this is a blind insertion technique, and we have the risk of perforate the urinary urethra and bladder. So there is reported incidence in these perforations in bladder from 0.6 up to 33% in the urethra. When the polypropylene mesh gets in contact with the urine, this produces immediately incrustation, infection, inflammation, and bleeding. The open abdominal and transvaginal resection way is complicated and morbid, and this is why some endoscopic techniques has been described for the treatment of this as standard transurethral resection, pneumatic lithotripsy, transurethral endoscopic resection with laparoscopic assistance, and the transurethral endoscopic excision with the Holmium laser. So our objective was to evaluate the efficacy and the security of the excision with the Holmium laser in a retrospective series of women with a previous mid-urethral sling surgery for stress urinary incontinence or other pelvic surgeries with a mesh or suture exposition into the urethra or bladder. The successful treatment was defined by the absence of the exposed mesh at the control cystoscopy, and the outcomes included resolution of the symptoms and retreatment due to the persistence of the exposition. Our population was 21 women that were referred from our gynecological department and from other hospitals. The mean age was 69 years. The previous surgery was 18 for stress urinary incontinence patients and 3 for pelvic or gynecologic surgeries. The median onset of the symptoms was 108 months after the surgeries, and the complaint, the symptoms was dysuria and micturition pain in 48%, urinary tract infections, and urgency and frequency. The cystoscopy localization of the lesion was mainly in the urethra and the left bladder wall, but also in the bladder neck, in the right bladder wall, in the trigone, and in the anterior bladder wall. Our equipment and settings was a two-way continuous resectoscope with 120 watts Holmium laser equipment, 550 fiber, and 1.5 and 2 joules energy, and 10 to 30 hertz frequency. The mean surgery times was 46 minutes. Mean hospital stay 1.3 days. Mean bladder catheterization 2 days. We didn't have any Clavien-Dindo 3 complication. At the cystoscopy control in 3 months at least after the procedure, we have 19 patients that present reepithelialization of the surface of the mucosa, and only 2 patients presented persistence of the exposition of the mesh, and we perform immediately a retreatment going deeper in this patient, deeper in the submucosa. And with a median follow-up of 21 months, we have 100% of the patients asymptomatic for the complaint that they present to our office. So, well, this is a little clip movie of what we've normally found is a mesh exposed and incrustation of a stone in the mesh. We have to remove it, and when we have removed all the incrustation, then we cut the mesh. and pull it out with endoscopic grasper. So our conclusions are that patients with genitourinary voiding symptoms or recurrent urinary tract infections associated with antecedent of stress urinary incontinence, sling surgery, or other pelvic surgeries may present urethral or bladder exposition of a mesh. That the endoscopic excision with Holmium laser is a minimal invasive technique, effective and safe, with good symptomatic and functional long-term results. And we have to advise our patient that if we do an intervention for treat this, maybe there is a risk for a recurrence of stress urinary incontinence if we have to section all the mesh. Thank you.
Thank you. Discussion and questions?
Yes, thank you for a nice presentation, nice video. I have a question on your number 3 conclusion over there, because we have a slightly different philosophy, because we get referred in a lot of patients who have had a prior laser treatment and who still have pieces of mesh. So we typically are more likely to do a transvaginal or some other approach to get much more of the mesh out. And one of the downfalls of that is that there's a relatively high risk of stress incontinence with that approach. So the question is, what was the rate of stress incontinence in these patients?
For the 19 patients that underwent the previous 18 patients, previous stress urinary incontinence surgery, because the other 3, I'm talking about this series. We had 18 patients that underwent stress urinary incontinence surgery. The other 3 were pelvic surgeries. Okay.
Yeah.
For this patient, the only 2 recurrences, persistence of the exposition was 1 TOT and 1 TBT. So we have to retreat these patients, and we go deeper, and we section all the mesh. So these 2 patients recurred with the stress urinary incontinence. So the other 16, no.
That's very good. Okay.
Any more? If not, then we'll move on. Thank you very much.
Okay, thank you.
Thank you.